Good afternoon, everybody. I think we're closing it out. I think we're ending it on an amazing note for you. If everybody wants to stand up for just a quick second and maybe take a big stretch, as we are at the home stretch now. Here we go. Nice to see an audience. I love it. My name is Mustali Dohadwala. I'm a clinician. I'm a clinician in invasive cardiology. I own my own practice a little north of Boston, Massachusetts, called HeartSafe Boston. I've been doing it for about 15 years. And I have a patient panel of about 3,000 patients. So, yeah. Why don't we have a seat? Just gonna take a moment, and if everybody can introduce themselves, we'll start with the ladies. Sure.
Hi there, nice to meet you all. It's the final day and I'm finally getting over the jet lag. I work in clinical trial data transparency, so I have other experience within the pharmaceutical sector, but data transparency is my thing right now, so we focus on data sharing and access to, just making information more easy for the public to understand and fighting misinformation. Thanks so much for having me, guys.
I'm Dr. Nilan Kavil. I'm a clinician in the long-term care sector. We deal with post-acute long-term care. In addition to that, I'm an AI advocate, AI in healthcare. We build predictive analysis for patients.
Of course, I'm Andrew Paxisian. I'm part of All Care Home Health Provider. So we provide services at the home for post-acute at home, and also part of the National Alliance for Home Care at Home, and being part of California, on the board of California Home Care Association. But also, my previous life, I was an engineer in computer and electrical engineering. But now I've been into population management and health, but that's where my expertise is in the post-acute space.
And I'm Peter Axe, the chairman and CEO of Upscript Health. We partner with pharmaceutical companies to develop solutions for direct-to-patient care. We do that with a basis of telemedicine. So if you think about our business, if you were go to a branded drug website, for example, Ubrelvy, if you suffer from migraine headaches, you would see a pop-up that says, would you like to talk to a telehealth provider now? Would you like to see if Ubrelvy is right for you? Would you like to see if there's a way to treat your migraine headaches with something other than Ubrelvy? You'd click on that button and you're on our platform. And we serve almost every major pharmaceutical company in the world at this point. Been around for 20 plus years. And we're developing more and more complicated solutions than just sort of providing a medication treatment on the web. So.
Amazing to be around such thought leaders, such well-accomplished thought leaders. It's great. Just want to start something off by sort of get our juices marinating here a little bit, if possible. If you guys can just briefly tell me at this point where we are right now, what do you believe will truly elevate the patient experience?
I think it's about using digital innovation and that human healthcare to try and elevate, and find out their needs as well, and just not missing out the human element. Because I think there's been a lot of discussion about AI, but then that kind of dehumanizes what the patients really are after, and it's the patients whom we serve. So we should really focus on what their needs are. I think that's
it's a fine balance, is what I'm hearing from you.
Yeah.
According to me, it's like we're not doing a personalized patient care. We are more into the traditional methods of care. So we need to personalize the treatments we have to meet the patient where they are. That means at home, location-wise, or depending upon what their needs are, like, in the home, safety of the patient. All that is the concern that I would think of, personalized medicine.
And I would say, health literacy, just to compound on what you're saying is, how do we configure a great experience for the patient, but also take a look at the whole health system, from doctors down to the home meds as well. How do we make useful time for everyone? Again, we're stretched thin as far as the healthcare experience, but how do we make it more welcoming, coming from the doctor's side, coming from the hospital OR, God forbid, but also at the home, but also elevate the community to make sure that they understand what disease process is in their own terms, and if they're able to accept it or not and comprehend. And we should be able to take that journey with them together to enhance that experience.
So we're all mentioning tactics. These are real tactics, ways to improve healthcare and elevate the experience. But you really have to go beneath that, in my view. And you have to look at the system. We have a really very broken healthcare system. And until you fix the fundamental of that system, which is cost, you can't really worry about anything else. The tactics, you can try and get an extra minute out of a physician's time to get a little better treatment, but you really have to look at the cost structure. If you look at Western countries in the world today, our healthcare costs are double per capita of any other Western country on average. We have probably the lowest outcomes in the Western world in healthcare today. So the systemic problem is all built around our structure is wrong and the cost structure is wrong. And just some symptoms of that, you have PBMs that literally double the price of medication so that they can get 50% rebates. You have clinicians that are reimbursed at awful reimbursement rates. They're not really allowed to be able to deliver good care. And the list goes on and on and on. So the question about elevating care is really complicated. It stems from a cost structure that doesn't work, and then we can fix the symptoms in the meantime, but that's my thought.
Yeah, it's fantastic. I mean, you're 100% right. It's extremely complicated. There are many nuances to this. But if we can try, would it be possible to identify other barriers besides cost, which is certainly the most important, which I completely agree with you there. What other barriers do you foresee? And perhaps, do you have a solution how to navigate around or over that barrier?
Yeah, I think another thing, because this talk, the title is about patents, and I'm guessing with that it's like intellectual property and aspects of competitors. They don't want other people getting access to information, but I see more of this as a collaboration, not competition, because we're all there for one common shared goal. And so intellectual property, and so what if someone else gets access to, I mean, I know there's like aspects of trade secrets, but someone can think, oh, we can collaborate and make something great together. So I think that's the solution, really, is collaboration in terms of that aspect.
Dr. Cheryl?
I would think of technology as a solution to this, because my realm is that, and I see that it helps my patients. We are able to, in my practice alone, we have 4,000 patients in our practice. We were able to cut down readmission rates from the SNFs due to use of technology. So I think technology, predictive analysis, looking at what the patient needs and what is, focusing on those aspects, the RPM, real-time metrics, that is what is going to elevate the experience, I think so.
I think, taking a look at EMRs and taking a look at every, facet of the healthcare system. Take a look at the hospitals, you take a look at skilled nursing facilities, you take even home care. They're all in their own silos, and we can't really share this information readily. Again, I go back to how do we make most efficient of time for each part of the care continuum, but also how do we make it appropriate for our patients, right? At the same time, we're just kind of like pushing it down their throats, like, hey, this is what we've learned, right? But how do we bring it back to this is what the patient wants? What can we emphasize? What can we really take a look and have compassion about them, right? Really hear them and where they're at, meet them where they're at, right? And then now we could bring it back. And how do we reach those synergies where we could have all these information, interoperability, even though it's a big buzzword right now, but how do we make that real? So at least it's making best effective time for everyone here in each one of their silos. But at the same time, using AI stacks, such as RPM, such as generative AI, and make it useful for the system, but also make it very personalized for the patient, right? To make effective, efficient work, to hopefully see some cost synergies as well.
These are all great thoughts. I think the best way I can answer that is by telling you a little bit about how we do business and our business model. Because what we've done is to say there's a lot of friction in healthcare delivery, and let's find the pain points and let's resolve that friction. So for example, when you go to that website and you're interested in a medication or a treatment, or we even treat things like sickle cell anemia. If you suffer from sickle cell anemia and you want to examine a new drug that's out, you click on a button and talk to our telehealth provider. That telehealth provider's going to be available when you want them available, number one. Number two, they're going to be trained on that disease state and all the other options in the market. Number two, education. Number three, we're going to make it inexpensive for you to have care online because we can be really efficient with the use of our clinicians. Four, we're going to work with your payer, your insurance provider, and determine whether or not you need a prior authorization. If you do need one, we'll prepare it 100% of the time, whereas in traditional markets, PAs are prepared about 50% of the time. So we'll prepare the PA, we'll work with the payer to get coverage, and we'll do all this seamlessly so that the patient doesn't have to deal with that pain. We have patient support people dealing with that. And then we'll ship the medication right to you. So we take away all these friction points in healthcare delivery, and that's kind of our aim. And we believe that's a new channel and it's a new way of looking at healthcare, and that's kind of what we've been defining.
Yeah, tremendous. I mean, I feel like all the solutions that you guys offered, I mean, I feel like we're not navigating around, we're not jumping over, we're flying over these barriers, so that's great. You got some really thoughtful people here on the panel. Appreciate that. I'd like to introduce some framing thoughts, to do a little bit more of a deep dive into this concept about patient experience. And I'd like us just to think for a moment, what defines exceptional patient experience without exception? Let me repeat that one more time. What defines exceptional patient experience without exception? So I'm going to start with empathy. How do we reintegrate empathy? Now, some of us here are clinicians. Some of us work closely with clinicians. I'm sure we all have something to say.
Thank you. Yeah, I think with empathy, it's also about thinking about just their perspective, and also we've all been in a state where we've had, clinical treatment or we needed help from the doctor. So just think, what kind of information would we want from like a healthcare provider, or what kind of information would even our caregivers or our loved ones want? And it's having that kind of heart to think. And I think with empathy as well, in this current age where we kind of look towards more digital means, we've still got that human aspect, so we should stay connected. So I think that's a huge part of empathy for me.
Thank you.
I'm going to be honest here. 15, 20 minutes of our time, do we really know our patient? That's the question to all the clinicians. We really don't know. We are just addressing the scenario right there. We're not looking through what the patient is, what an individual is. 15 minutes doesn't do justice. You cannot develop trust with 15 minutes. You over time, if they're going to come back to you, yes, eventually you can gain that trust. Why 15 minutes? It's regulated. That's the truth, right? So we are driven by the payment, as he said, the cost. We have to meet our cost, and that's 15 minutes is what we get to see. So I think time is very, very important in order to build the patient trust. If there is trust, then of course it's an elevated experience.
I mean, we're pretty lucky over at home care where we spend a frequent amount of time with the patients themselves. I mean, we're not there forever, but we're there kind of intermittently or, for a set amount of time. So I have to kind of flip it on its head. But at the same time, you have to build that trust. At the same time, you have to have that understanding, like culturally, spiritually, with these patients to really gain that. So it takes some time, to really build that. But once you build that relationship, that warm touch, again, on my conversation on high tech and high touch, those are one of the biggest emphasis that we really emphasize to our clinicians, is really build it, and then now we start stacking on top information. Now we start stacking on behavior, and then take a look at it as well. Especially when you're at the home, sometimes you're going to have to question certain things. And then how do you gravitate that? And with that empathy, it's like you have to be in their shoes. You have to be in their shoes and really have that human connections to really make that influential change with them.
You're asking about empathy in the digital age, which is almost an oxymoron, right? But, you know, I tell you, my philosophy is you reward certain behaviors. And one of the things we do is we reward our clinicians for receiving very high patient scores, whether it's Trustpilot scores, a digital way to measure performance, or NPS scores. But we do surveys all the time of our patient population, pre and post treatment, and we try and learn, are they getting from the visit what they need? Do they feel heard? I mean, so much of empathy is about being heard, right? It's about being recognized for what you're going through and having someone listen. At least my wife tells me.
At least your wife listens to you. I think I think Dr. Cheryl, you brought up trust. I think it's a very important word for us to further examine and explore here. Dr. Peter, Mr. Peter, as well as Dewaki, can you guys share a little bit more about what that healthcare provider patient trust really should look like?
I think
I'll
trust.
start with you.
Yeah.
Peter.
Thank you. I think trust is about honesty as well, and for the patient to be open about whether their needs are being met and what kind of the healthcare provider can do to give them more. And I think it's important to integrate them into like interactive surveys, or maybe like patient experience is one thing, but patient satisfaction, you can determine that by, gathering their thoughts as well. Because it's all well and good to have people walking into the clinic and think you provided them with a good service, but when they walk out, you don't really know whether they actually had satisfaction in their experience or not. So I think trust is about whether it's good or bad, being open and honest about what the experience was.
Fair enough. Mr. Peter, I mean, for you, I think my question to you would be, in this digital age, are there metrics that can be utilized to help identify trust? And I mean, I'm sure you're doing that when it comes to assessing how well your providers are doing.
Look, that's a really interesting question. I think there's a qualitative analysis we go through and a quantitative analysis. And let's talk about the quantitative, because that's easy. The quantitative is we look, so in the telemedicine world, just so everyone understands, there's three modalities, right? There's a video visit you have with a clinician online, there's an audio visit you might have with a clinician, and there's an asynchronous interaction, meaning you fill out a question set, the clinician reviews it, not in real time necessarily, and they'll get back to you with questions. So in those environments, to best quantify the patient experience, you look at how long was the video call, how long was the audio call, you look at what are the digital questions that were asked in advance, what were the responses from the clinician, did the clinician follow up with specific SOAP notes in their medical records. You can look at all those elements and sort of come up with a quantitative analysis. But on the qualitative side, it gets back to patient surveys and overall patient experience. It gets back to things like return patients. Do patients come back? Do we see a lot of return? And we do. We see a lot of return patients in our organization, and if we didn't, I'd be upset, right? It's, you build trust with people, and if they come back to you, you've done a good job of it, and if they don't come back to you, you haven't done a good job of it. So the fact that we have patients remaining more compliant on meds, the fact that we have refills coming through regularly for our fulfillment partners, the fact that we have patients follow up with questions months after being treated, that's a really powerful statement that there's a real dynamic between the clinician that treated them and the patient. And being able to track all that, you can do that in the digital world, you just have to build the software. But that's sort of how we look at it from a qualitative perspective.
So Andrew, for you, I think about establishing a robust multidisciplinary care team more important now than ever. Can you sort of expand a little bit more on that, please?
Yeah, when we, take a look at the patient home, right, and take a look at, multidisciplinary teams and take a look at the whole systems, it's vitally important that each system has its most important roles, right? Not only from like the pharmacy delivery, not only for the DME companies delivery, but also from, specialty units. But when we take a multidisciplinary, it takes I want to say a whole village sometimes, or probably a whole town or the globe, to make it real, right? But how do we make that information very, very pertinent and precise? And that's so difficult, during these days, because there's always this friction of push and pull, who's going to be there, who's actually going to get paid for certain things with it. But it's very important to really keep that patient in the center and what they really want too, right? To really having that listening type of perception and being heard, right? Because everyone likes to be heard. But once we have that and that iteration, what does the team have to value in what the patient has, and really accentuate that patient experience? Because if you're not hurting and just pushing items down their throat, they're never going to be appreciating us, right? Same thing with the health plans, same thing with certain modalities, is how can we get that patient-centered and really create those synergistic goals that the patient really wants, but make sure all the team members are lined up, right? But how do we make best effective time and information so everyone together could really reach those goals?
That's great. I think that for me, it is vital now more than ever to really focus on, shifting the way we look at diagnostics, treatment, prevention. We need to go away from the traditional metrics and look at granular metrics in order to truly establish this exceptional patient experience. And I think that when I think about granular metrics, I'm not thinking about what their traditional risk factors are, like hypertension, hyperlipidemia, diabetes, smoking. I'm thinking more about what does their food situation look like? Can they get to my appointment? Do I need to call a taxi for them? Do I need to make sure that there's a space for the van outside my office? And is it safe for them at home? Do they have a social structure at home?
So you're talking mostly like social determinants of health, right? Because that's a big thing from CMS these days, is do they have these access? And especially when we go towards the home, I mean, we're there often, again, like you said, with food disparities, if they can't get over to the physician's, clinic, right? Do they have mobile services? Maybe the helpline has it or not. Are they able to transfer train? Is there a caregiver there, right? Because when you have a patient going over to see their physician, or even during a virtual call, you may not see what's in the fridge. You may say, hey, I'm eating well. What does that really mean, right? You can see that over video chat, but not until a person, either a caregiver or one of our clinicians, opens up the fridge and like, no, this person needs some help, right? Or, same thing with, my culture. We eat rice in the morning. We eat rice over dinner. Sometimes we make rice for like dessert, right? Oh goodness, right? Some people here are like, oh yes, I could relate to that, right? But sometimes, that you can never take away, right? Because that's culturally ingrained, right? And those are like one of the biggest things, like how can we really modify certain items? How can we aid and accelerate? We definitely going to have to meet them where they're at. And I think you discovered a cultural disparity with your AI models, right?
So what we do is we take consideration of the patient's, all their health, the home situation, and we do all the factors, embed all these factors. We have a questionnaire, we have an inpatient, as you told me, there's an intake person who goes in and sees the situation, puts it in, for the clinician to review. Right now what happens is all the modalities are, as you said, they're all in Xylo. They're all working, but they're all in different spots. But I think it's like if the music, let's consider the patient as the music, right? But the orchestra, it should be together. The drums can't play separate. The violin can't do its job. Everybody's doing their job, but it's not together. So who's going to coordinate this? And for me, I think it's technology that's going to coordinate this.
I totally agree. It's like, how can we accelerate it? We have all the data there, but how do we bring it all together to make it informational? get rid of the noise. And again, I think when we're talking about it, it's like, how do we make that information specific for each doctor, so each modality, to the caregivers as well, instead of looking at all these big things which are so overwhelming, but how do we make it very specific in the orchestra that we're trying to create for the patient themselves?
That's fantastic. Thanks for making an intro to my next framing thought. I think we really don't have a choice. Horses out of the barn, the train's moving, healthcare delivery is evolving or has evolved. I'd like to hear more from Peter and Bucky again regarding what is your take, especially in the virtual medicine space, on how do you empower patients over a video call or a telephone? How can you empower your providers to be able to have those more difficult conversations regarding overall prognosis, what's realistic, what could be wasteful, what is empathetic when it comes to efficacy and healthcare utility?
Sure, and that's a really complicated question. And I think the first point I want to make is not every patient seeking care should be going to telemedicine. There's just a lot of ailments that shouldn't be treated through telemedicine. But generally speaking, our patient population is filled with people that are informed about their disability or their disease state or at least what their symptoms are, and they can be conversant about what their symptoms are. And then they can have an intelligent conversation with a clinician who really needs to collect information. And again, we reward our clinicians to collect information and make a decision. In medical school, you're taught that 95% of a diagnosis is information-based, right? It's not touching your knee or feeling your skin most of the time, the vast majority of the time, it's gaining information. So we really encourage gaining more and more information. And we also have a culture in our organization. You talk about empathy, and you raised the question of empathy and made the point. And one of the things about our organization is our culture from the very top down is all about doing the right thing. Whether it's our pharma partners, whether it's our patients, whether it's our clinicians, whether it's our employees, it's always doing the right thing. Our decisions are never made based on dollars. They never will be made based on dollars, no matter who our equity investors are. And we will just always try and do the right thing and embed an integrity that the clinician is going to be empathetic, is going to gain information that they need to make a diagnosis or to treat or to assist the patient, and they're going to hear about the patient's problem and be thoughtful about it. I don't know if I've answered your question, but hopefully I've at least gotten most of it.
Lots of insightful thoughts there.
Thank you so much. I completely agree with Peter on, doing the right thing and all the things you mentioned about integrity as well. I think with the patient experience, it's also important, like from an information perspective, I also agree that they need to have all the information, whether it's like, there could be information that kind of is very difficult for them to understand, but then it's that fear of the unknown that can make them go back and feel worried. And a lot of the talks in the conference I find has been more towards herbal medicine as well, and there's been like a bit of demonization of pharma and the drug development industry, and of course there's bad people in every industry, but it's about making sure that information about herbal and chemical or drug interventions are out there for the patient to make their own decision and not to have like a biased opinion to push them towards one thing or the other, but to help them make an informed choice. I think that's what really matters, to empower the patient. Like, here's everything you need, and if you need any other questions answering, just feel free to reach out and just be like an open book. I think that's true empowerment.
Excellent. I see a big pink elephant in the back of the room, and I'm not sure if you guys do as well, but I think I think there's a tremendous shift in paradigm, a philosophical shift as we move from a fee-for-service, transactional, volume-based healthcare delivery system to a value-based system. And I truly believe that this will allow us to very shortly prioritize our patient-provider relationships, of course. But I think it's going to allow me in particular to focus on prevention of cardiovascular disease. It'll keep me from over-treating, perhaps even under-treating. And then finally, I think from my standpoint, I do believe that we're going to better focus on quality of care rather than the quantity or duration of care, life. Dr. Cheryl, I know that you in your space, I mean, you probably deal with the sickest with chronic medical conditions. Do you have any thoughts there?
So I believe prevention is better, like especially in chronic conditions, right? Like most of my patients have at least, if you look at the chart, they'll have at least 20 diagnoses. And there'll be almost 30, 40 prescriptions from different modalities. So with chronic care, we have to imply prevention as the first thing, but how do we prevent it? How do we prevent hospitalization? That is where diagnosis, I don't think only providers could do justice to, we can't do all the notes, we can't read the 20-year worth of record, we cannot do it, it's humanly not possible. That's where I think technology is the only way to go, is the only way to go to reduce this. And wearables, wearables give you an idea of the patients. Assessing who's critically ill, who needs the most attention is very hard in a sector like mine, especially. In a SNF, you have like 200 patients. So every day, everybody is chronic. So, and as a provider, you cannot be attending to all 200 patients every day. But who's watching them? That's the question. Who's keeping up with their metrics? Who's doing their vitals? Yes, long-term care, we have nurses who do their vitals. But are they all, are they using devices that is FDA credentialed to do the vitals? Or are they pulling off something from their Amazon shelf and just doing the vitals? What is the credibility to all this? That is what is important, in chronic care. Unless we bring in all these modalities together, we're not going to be able to manage these conditions.
Thank you for introducing my next and last framing thought. I promised we did not do a dress rehearsal. Promise. I am anticipating in a very nervous way the future of medicine, the future of healthcare. I imagine, potentially health bots curating a personalized, right, precision-centric approach in treating, colony members on Mars, right? But all joking aside, I think we've got some thought leaders here that are innovative, and I'm curious to hear from them what the next 5, 15, 25 years looks like. And let's start with Peter regarding the digital first solutions.
Sure, and you've already touched upon it, but there's no question the next decade is going to be about AI, and it's going to be about a transformation of care and delivering it using agents of AI that are smart, that are efficient, that can absorb more information faster, and that can somehow elevate the patient experience while at the same time reducing costs very dramatically. I do think a systemic change because of AI will impact the cost structure of healthcare and really be very, very helpful. Now, for that to really happen, though, a number of things have to occur regulatory-wise, because we have real issues with our regulatory structure in this country, and the most blatant example in my space is, in my space of telemedicine, is that we have 50-state credentialing of physicians, 50-state rules you have to use, and you have to be licensed. If you're a clinician and you want to treat across state lines, you have to be licensed in multiple states. Why is that? Why don't we have a national licensing structure? Why don't we have a national licensing structure for pharmacists? Why do we have antiquated corporate practice of medicine statutes that require all telemedicine companies to create arcane structures, legal structures, to accommodate rules that make little sense in the world of HMOs and other types of corporate organizations? So there's a lot of things that happen to occur regulatory-wise, and we haven't even touched upon how regulations have to manage AI and the use of AI. But I caution the United States not to be overly concerned about safety of AI and get worried about what the problems will be before they allow certain things to occur and let us see how this develops. But at the right time, we are going to need regulations around all this.
Fantastic. In line with AI, artificial intelligence, how do you see it incorporating itself in personalization of medicine, precision-based medicine, where we're essentially providing each of our patient members a prescription, an individualized prescription for their, let's say, 20 medical problems?
So that's where you can bring in the genomic study. That as I said, we cannot do it all. We need artificial intelligence to do it. So the genomics, their lifestyle habits, their real-time metrics, all this has to be put in together and then delivered, then cultural aspects to it. So if a human person cannot combine all this and develop a personalized care. So for example, as you know, I would say not all medications work for everybody, correct? But now we are just using a standard of care. Am I right? Aspirin might not work for him. The examples are a lot. So what I want to do is what we want to bring up is personal. Don't do the testing methods right now just because it's there in the standards. Now, what are we doing as physicians? We give them, we trial the medication. If the blood pressure goes down, okay, well and good. Continue for the next six months, and then we come back. Oh, it's not working. We do another one. That's because we don't know the other side of what the patient's doing. We need to know what is their genomics. Why is it coming? Culturally, what is their ethnicity? That is very important.
So you're talking about a lot of data endpoints,
Yes.
right?
So-
How do we make those endpoints meaningful? Perhaps, Andrew, I don't know if you want to chime in and
Sure.
share your thoughts.
So we have so much, me as an engineer, it's like we have so many things going on. Again, I agree, genomics and being very precise, right? We also have a little bit of empathy, is are they willing to? Again, from the regulatory side, it's we have a lot of hurdles to go through. I think the current day right now is what is the patient acceptance of using it as well, right? But also give the realization in 5 to 10 years, how do we use technology to really accelerate it? Be customizable for it, because we have everything allotted for us. But the guardrails of our government has to be in state as well. And I think, all of us goes down to the hill and really advocate for what we want for our separate industries. Mm-hmm. But also try and take a look at it, if we kind of flip it on its head, what is the future that we have with technology? What was the outreaching future? What is that invention of it? Again, Steve Jobs brought up the iPhone and revolutionized it. I think in healthcare, we're at this crossroads where we should be able to utilize that to our advantage, really, and be cost effective, be efficient, but also be very precise of what that genomics and what the patient needs, and also hear them out. And also Congress has to hear us out as well, to add on.
Lucky, what do you see the future when it comes to patient data privacy? It's truly fascinating. I think it's going to become an ethical dilemma very soon, if it already hasn't come up.
Yeah, definitely. I think AI has raised a lot of ethical dilemmas as well, because AI has advanced in areas where it's not been put to good use, but it hasn't advanced so much in areas where it could be more meaningful. So I think it's about having that constant connection with the patient where they can, that they're not forced to, accept that, if they're in a clinical trial, they can leave at any time, or just give that open space as well. I think data privacy as well, it's hopefully the legal and regulatory aspect is changing surrounding AI, and that will be quite interesting to see in the next decade or so, but is expanding quite a lot.
I don't know who here in the panel is familiar or very familiar with the brain-machine interface.
Talk about Neuralink.
That's right, Neuralink, right? I mean, as some may or may not be aware, but more recently there have been some very elegantly put together preclinical early phase studies showing a tremendous advantage with this particular technology and helping people that are tremendously debilitated, predominantly physically debilitated, but potentially even mentally debilitated by implantation in a very invasive, minimally invasive, or for that matter, non-invasive methodologies in stimulating the brain. What do you foresee when it comes to privacy? How do you handle privacy? That data that's there. Remember, there is a computer, and there's a mini computer, there's a microcomputer in somebody's brain. How do you handle that data? How do you handle privacy? Who owns it?
Well, it's all considered PHI, right? Personal health information, and there are lots of rules around PHI under HIPAA. So there are rules in place to restrict access, to restrict how it's stored, to restrict how it could be used. So, and I do think that they're quite effective. And then the question is just enforcing HIPAA audits of organizations that have this data, and to be sure it's enforced.
So, I mean, I think one thing that's provocative, I think, to say the least, is this architecture has been put together by some really, really smart people, engineers, scientists. They've essentially curated, a treatment plan for this particular patient member. Do they not have any intellectual property value in that data?
I'll make sure I understand the question. You mean the engineers who have designed the software?
Correct.
Who are using the data. So, we're a good example, right? We have dozens and dozens of engineers, and they have access to all sorts of PHI. To become an employee of ours, you have to sign a dozen different documents, including trade secret rules and secrecy laws, and then HIPAA compliant documentation as well. And so, we think we contract around that. And then we only allow access to those engineers that have to have access to that. And we keep a strict flow chart of who should be allowed access. For example, we have patient support people all the time dealing with PHI. Well, there's only certain patient support people that can access certain aspects of files. And you have to build your software that way so that you can control access and you can password protect access. And look, and then we're all susceptible to cyber breaches, right? We're all susceptible to threats, no matter how robust our systems are. And that brings up a whole another whirlwind of issues and problems.
Yeah, I was going to bring up interception of signals, electrical interference. What happens if that small, seed-funded company that has this phenomenal new microchip ends up going belly up?
Well, so by the way, you're bringing up a really interesting question, because one of my theses in the world I speak in venture capital, is that we have created a system in the United States, and data is getting so complicated that it's really very difficult to develop startups. It's really a very difficult, unless you are a well-funded startup with tens of millions of dollars of venture capital behind you, it's really difficult to start a company today that you can grow and expand on. And that's one of the reasons is cybersecurity, the integrity of data and maintaining its security.
What do you do with downtime? Well, I think
that's 5 kids. How about that? 5 kids.
I think that's all the time that we have. I just wanted to give an opportunity to ask folks that may have any last minute questions. I think we are the last panel, so I think we do have a couple of minutes, I hoped, for any questions or comments.
But we are going to be available after this. So if you want one-on-one time, we're all here.
Thank you, everybody.
Thank you.